In the seventh session of the Ohio State University Nisonger Center ECHO on improving services and supports for individuals with intellectual and developmental disabilities and mental health conditions, we will be hearing from Liz Poprocki, Mental Health Treatment Coordinator at the Ohio Department of Mental Health and Addiction Services. She will be speaking about the department's Access to Wellness initiative. Our learning objectives today, we would like participants to be able to identify participant eligibility criteria for the program, to describe how systems collaborate to provide supports and services, and to list common types of recovery supports. At this time, I'd like to thank and welcome Liz to the stage. Thanks for joining us, Liz.
Thank you all so much for having me. It's a pleasure to be here with you today. I hope everyone had a restful holiday and ate a bunch of good food because I know I did. So coming off of those couple days, it's been a little challenging. I will do my best to keep up with if there's anything in the chat or if anyone has their hand raised as I go through this. But please, your patience is welcome. So we're just going to dive right in here to the Access to Wellness initiative with our program goal. The goal of this particular program through the Department of Mental Health and Addiction Services is to provide a very strategic, collaborative effort to provide individualized wraparound services to adults with severe and persistent mental illness who are also touched by other systems. This used to be formerly called Multi-System Adult Program. We felt that that was a bit stigmatizing in its name, so we changed it to Access to Wellness. For those of you who are very familiar with our programming here at Ohio MOS, we understand that this is quite confused with Access to Success, which is a totally separate program. So I want to make that distinction out the gate. To give you a little bit of background on the Access to Wellness program, Governor DeWine introduced this initiative in his state fiscal year 22 budget. At the time, the project received $11 million over that biennium, and it was supported by Ohio's General Assembly. Since its success, after a first couple years, it received an increase of $1 million for a total of $12 million in funding in our current biennium. We have 47 of the 50 county ADAM-HS boards who are participating. The way that this money is done is an allocation that is made to our county mental health boards. The county mental health boards then process that funding with their behavioral health providers who are contracted with the board through this program. So what it is that we have the allocation sent to the mental health board. Mental health board then determines how that money is spent across their community or communities for those county boards who have multiple counties. To be eligible for this program, there are 5 different criteria. So an individual would need to meet one or more of the criteria I'm about to show you to be eligible for this program and receive recovery supports. The first criteria is as such, an individual can have 2 or more inpatient psychiatric hospitalizations within the past 12 months and touched by one or more of the following systems. So in 12 months, we're looking at December 2nd, 2024, all the way to December 2nd, 2023. And that would be our 12-month span. The systems that we have identified are as follows. They can be involved with aging or over the age of 65, criminal justice, so AOT, as outpatient treatment programs, probation, they may be involved in a specialty docket. Criminal justice means that there has been contact with the court system and they are working with the court system through episodes through their recovery. It does not mean police contact. That is not included within our eligibility criteria. Developmental disabilities, an individual has to be working with their county board of DD, who I see a bunch on here today. So if I'm repeating what you already know, my apologies. But I hope this rejuvenates maybe energy into the program. Homelessness, this is quite a spectrum. So when we talk about homelessness, we're talking about folks who have been unhoused, unsheltered for a number of years, all the way to individuals who may be facing eviction from their current apartment or living situation. We've helped a number of individuals who struggle, obviously, with severe and persistent mental illness, who maybe have a hoarding situation and require cleaning of their apartment, their living space, to be able to keep it without being evicted. And we will use the funds for that. Another option is veterans. Now, an individual can meet any or all of these. So they can go through all of the different criteria. They might be involved in criminal justice and homeless and are a veteran. And we see that quite often, where an individual doesn't just meet one eligibility criteria, they meet multiple. Before I move on to the next eligibility criteria, I do want to make a very clear distinction that to receive services from this program, obviously they need to meet eligibility criteria, but their primary diagnosis must be a severe and persistent mental illness. We see a lot of folks wanting to utilize this program with a primary diagnosis that is other than SPMI. It may be that they have an SUD diagnosis and mental illness is secondary. Unfortunately, we do not accept anything that is less than an SPMI diagnosis. So they would need to meet that criteria, obviously. And I think that that's backed up with the inpatient psychiatric hospitalizations as well. So one of the things that we saw a lot in the development and the evolution of this program was that we have pockets across the state of Ohio that do not have immediate access to inpatient psychiatric facilities. So whether they're waiting on a regional, one of our state psychiatric facilities on a long wait list, or a private psychiatric facility may not have the level of care needed for this individual. So we opened this up to include crisis stabilization units as well. So an individual could have 2 or more CSU stays within the past 12 months, and again, touched by one or more of those systems that we just covered. Eligibility criteria number 3 also recognizes that sometimes 2 inpatient psychiatric hospitalizations can be extremely difficult to have, so mainly because of the location across the board. So we did a combination of the 2 with 1 inpatient psych hospitalization and 1 CSU stay within the past 12 months, and again, touched by one or more of those following systems. Christine, I see your hand raised.
I have a question. Have you ever heard about this? Just in curiosity, this other program called Station MD, that's made for people with intellectual and developmental disabilities to prevent having to go into the psychiatric center, because if they are because we know there's so many rural areas that can't get into those psychiatric centers because the waiting list is gigantic, and some are not even specializing in people with DD, that having this is an option for immediate needs, and it has honestly reduced their chances of going into the hospital over 70%.
Wow.
Did you even know that?
I did not know about that program, but I'm happy to learn more. If you have information about that, I'd love if you put it in the chat or email me. I'd be happy to learn more about that.
Well, I'm saying it's a healthcare assessment, being in all the DD waivers, but it's a way to prevent emergencies. And if people have emergencies for mental health because they need meds, or they're having an emotional breakout, okay? Well, this service has reduced hospitalization by 70%. and it's in the report we did, just to share.
Thank you so much. I appreciate that. Eligibility number, oh, I'm sorry, I thought I heard somebody else. Eligibility criteria number 4. We noticed, for those of you who work in the field, you're very well aware that not a lot exists funding sources for folks with SPMI who are also involved in some of our criminal justice programs. One in particular is our outpatient competency restoration program. So those of you a couple years ago might have heard about Senate Bill 2. Senate Bill 2, what it did is it folks with nonviolent misdemeanors are no longer hospitalized in our state psychiatric hospitals for competency restoration or evaluation. It's all done outpatient now through our forensic centers across the state. So with this in mind, we opened this program up to these individuals. And what we have found is that judges, courts are more likely to agree to allow somebody to participate in outpatient competency restoration if they know they can participate in the Access to Wellness program, because it will provide stability for them in their community and help cover some costs that they otherwise might have difficulty maintaining during their recovery in the community. So in regards to outpatient competency restoration, we are waiving the inpatient hospitalization, the CSU stays, and system involvement. Like you've seen before, we've required that, but with this one, we know that they're already involved with the criminal justice system and already have a mental illness of some sort. So they have to have that significant mental health diagnosis by a licensed professional, and the box with the criminal justice has already been checked. The last and final eligibility criteria has been one of our most popular eligibility criteria. So we are trying to mitigate the incarceration of individuals with mental illness. So what we've done is those folks with a significant mental health diagnosis who are currently incarcerated in jail, we can't do retroactive, we have to do right now, and are in need of supports upon release, can receive assistance from the Access to Wellness program. What this has done is it has begun to bridge a gap between our mental health boards, our behavioral health providers, and our jail systems. We have a lot of communities across Ohio that have been doing that very type of collaboration for a very long time, but we have some others where it might be very new. So in hearing some concerns from sheriffs and their deputies, we wanted to open this up to hopefully try to mitigate and put in some prevention in a way for future issues down the line. Thank you, Christine, for putting that in chat. I appreciate that. So to receive these funds, there has to be systems collaboration. It's an allocation made to the boards. The boards simply can tell me, hey, Liz, I want to participate. Let's do this. We go through an onboarding process. But one of the things they have to be able to show to receive the funding is systems collaboration. This looks different across the board. So we have 47 different county boards that are doing this. It looks different. We have some folks who have a monthly meeting that includes a lot, if not all, of the folks that you see on this slide. We have some boards that meet quarterly with their folks that you might see on this slide. And we have some boards that have a core group that they meet with, and then they bring in other folks like aging, DD, guardianship, veterans as needed to fit that individual's wraparound services. So the folks that you're seeing right here are who we typically see around the table when there's an Access to Wellness meeting. What we did, because nobody needs any more meetings these days. I think a lot of us have so much on our plate. So what we have done is we've said, if you already have a standing meeting, you can piggyback on that, add Access to Wellness to your agenda, and allow this multi-system communication to start happening around folks who are receiving services. Recovery supports. I'm going to show you a list of recovery supports we typically see. I know I've got about 10 minutes here, so I want to go through this as thoroughly as possible. The list I'm about to show you is not all inclusive. There's so many more that folks have been really creative in thinking about. Our boards have been creative in coming up with ways to support folks. But you'll see some examples here, all the way from helping with rent, security deposits, hotel stays for temporary lodging if needed, guardianship fees, emergency basic need items such as food, hygiene products, clothing, prepaid phone and minutes, all the way to sustainability of this program at the provider level. So what we've done is we've allowed these funds to be used for provider program staff for this program, not at the board level, but at the provider level. So we can pay time and rate for their services that are dedicated to this program. And we can also provide a 10% indirect fee to cover accounting, bookkeeping, the fiscal side of things to manage the funds that are going through our programs. A couple examples of unallowable expenses. Now, I am not an attorney by any means, but the reason for a lot of these unallowable expenses are simply legal issues that we as a state entity cannot take on. So we cannot pay for bills and expenses that are not in the eligible client's name. We will not cover a purchase of a home or home insurance, major home repairs, unreasonably high cost items. So for instance, we will not be able to cover a washer and dryer that costs $2,500, $3,000. We understand inflation and we understand that sometimes that can impact the cost, but we do expect the caseworkers and the staff working with an individual to be able to see what is reasonable for their needs and what isn't. Just to move through, we cannot cover court fines, particularly restitution, in the case of a violent crime or where there is a victim involved. Purchase of a car or motorized vehicle, passports, if they're leaving, if they are from another country and they're moving back to their country of origin, or board attorney costs, etc. Per client cost. So we do have a per client cost on this. There is a cap. We will be able to provide up to $8,000 per individual per fiscal year. It does renew every fiscal year, but I want to be very clear that the individuals are not entitled to the full $8,000. So there has been some misconception in the past that individuals will receive full $8,000 in recovery supports, but we have folks that don't need that much, and we have folks that need to go over that because their needs are so complex. So there is a limit, and it's based on clinical judgment and client need. So we rely on the county boards and their behavioral health providers to assist in making those determinations. Part of that is because this is a funder of last resort. So every other option needs to be tapped before, except for the exception of levy funds. I want to make that clear before tapping in access to wellness. We have some really generous communities in Ohio with some very generous levies. So if we were to say that those levy funds had to be exhausted, then these funds would probably never be tapped into. So all other local, state, federal fundings, with the exception of levy funds, needs to be looked into to support an individual before access to wellness. So we are currently doing a program evaluation, both qualitative and quantitative, of the Access to Wellness program. Thus far, we have yet to find another program that looks like it. So this data hopefully can be used to develop future programs, either here in Ohio or in other states. A couple things I wanted to share with you today as a thematic overview to an individual's success in the program. So we know that safe, clean, and stable housing leads to better recovery outcomes in the future. We're seeing that folks are being institutionalized less after the use of this community and program, and I'll share that with you here in a minute. We know that engagement with a coordinated interdisciplinary support team is critical to the success of this program and to an individual's success throughout their recovery. We are seeing an increase in medication and treatment program participation from folks who may have a history of not necessarily participating in their mental health recovery. And we are seeing an increase in folks getting jobs, having more income for themselves and reliable transportation as they are able to live and thrive and play in their communities of choice. So I know this is a lot of data crunched into one slide, but just to give you an overview, we've slowly increased over the last few years that we've had this program. In 2024, we added 2 more county boards for a total of 47 county mental health boards who are participating in this program. For those of you who don't know, there are 50 county mental health boards, and we have 47 of them in the program. In fiscal year 24, we served 1,746 individuals with these funds. We had 5 boards, some in our major metropolitan areas, that served 52% of the total individuals served. And for the 3rd year in a row, the majority of our individuals involved with the systems were with homelessness, criminal justice, and jail incarceration. That has stayed steady the entire time. And if anything, it's showing on a macro level the need for housing for these folks. So after receiving help from Access to Wellness in fiscal year 24, 81% of those folks did not experience another inpatient psychiatric hospitalization for that year. 90% did not experience further incarceration or incarceration at all. And 96% did not experience a crisis stabilization unit stay, according to follow-up that we have. So just to give you a heads up, we do a 6-month report, and then we do a year-end report from our county boards. It's about an 11-question survey where they provide us with some qualitative and quantitative data of those individuals that they've served over the past 6 months and then 1 year. And then just to give you an idea of how we're using these funds, you'll see that housing is the top need for our folks. In fiscal year 24, 87% of our boards use the funding for housing, and that could be permanent individual housing, their own apartment. It could be supportive living. It could be temporary housing, so hotels or another venue, so to get them stable in their community. We also do a lot of stopgap funding for housing. So where an individual is waiting for assistance from Recovery Requires a Community or another housing program, but their benefits may have not kicked in yet, Access to Wellness can then kick in and provide stopgap funding and support so we can house them. Emergency basic need items, clearly a top contender with 85%. And then transportation. We will assist in paying for ride sharing. We've paid for bicycles, bus passes, gas cards, things like that. Just a couple more things that we have provided under the Access to Wellness program: crisis intervention, peer support, assessments. I do want to be clear that anything that can be paid by Medicaid or another insurance source, we are going to tap into that first. We do not supplant with these funds. So if it can be paid for elsewhere first, then we are going to do that. In some cases, Access to Wellness will pick up what can't be paid for by those other systems. All right. And then I provided a couple, I won't go through them and read them to you all. I believe, Dr. Buck, they have access to all this information in the PowerPoint. So, and they'll have the presentation as well. But these are a few success stories that we've seen come out of the Access to Wellness program. This is all from fiscal year 24. So all of these are relevant and new. So just so I encourage you to read these all. I know that I'm out of time, so I don't want to run into your time anymore, but these are very interesting to hear how this has impacted folks across Ohio, and you'll get to see at which county board that they've been involved with. any questions that I can answer.
Thank you so much, Liz, for providing a comprehensive overview and some of these well-stated success stories about the Access to Wellness initiative. I invite everyone to share a comment or ask a question in the chat, or you can unmute yourself and ask any questions that you have at this time. Okay, if you have any questions as we move forward, or if you have any needs to access resources or additional information for Liz, as she mentioned, the PowerPoint presentation is available in our resources and will be posted on our website for future reference as well. Liz, I don't know if you need to hop off or if you're able to join us here as we transition to the case study. Thank you. She's also shared her email address in the chat should you want to reach out to her individually. Thanks again so much for taking the time to share your knowledge and expertise with us today. We'll go ahead and transition at this time